Now, I would like to introduce you all with our next chair, Dr. Shikha Agrawal, and our keynote speaker, Dr. Sai Hanuman Sagar Boddu, to our esteemed audience. I would like to invite them on stage. Dr. Rizwan Khan, the principal of SKICON, to greet them with a bouquet. Dr. Shikha Agrawal has completed her B.Pharm from SGS ITS in 1998, M.Pharm and PhD in Pharmaceutics from Dr. Hari Singh Gaur Vishwavidyalaya, Sagar in 2005. Madam has worked in Ranbaxy as research scientist. She has 21 years teaching experience. Ma'am has worked as principal investigator in MP Cost Funding Project. She is presently working as Professor of Pharmaceutics in Shivajirao Kadam Institute of Pharmaceutical Education and Research. She has guided 64 PhD students and has published 58 various reputed journals. Now, I would request Dr. Shikha Agrawal to throw light on the topic for Dr. Sai Hanuman Sagar Boddu.
Hello. Thank you, Arya. Good morning to one and all. I am really honored to introduce such an eminent scientist, Dr. Sai Hanuman Sagar Boddu. Sir is an associate professor of pharmaceutics in the College of Pharmacy and Health Science, Ajman University. Dr. Boddu holds 2 patents and has published more than 90 research and review articles in various peer-reviewed journals. He is a co-editor of the book entitled Excipient Application in Formulation Design and Drug Discovery. His interest of research in developing novel drug delivery system for treating various diseases, especially retinal diseases. Dr. Sagar has done his Bachelor in Pharmacy from Bapatala College of Pharmacy, Andhra Pradesh in 2003. He has done his Masters in Pharmaceutics from MBP Samaj College of Pharmacy, Nasik and Maharashtra in 2005. He has completed his PhD in Pharmaceutical Sciences from University of Missouri, Kansas City, USA in 2010. He has also worked as an associate professor in various reputed universities. He has honored for principal investigator and co-investigator in various researches. He also has various membership and award for his incredible work. Sir, I invite you for your talk on the topic topical eye drop for treating retinal disease. Welcome, sir.
Good afternoon, everyone. First of all, I would like to thank Dr. Trivedi for giving me a wonderful opportunity to present my work and all his hospitality for the last 2 days. It was very amazing, and I am very humbled to be here and be able to share my research with the eminent audience. So thank you, Dr. Agrawal, for giving me such a kind introduction. And my area of research is mainly into drug delivery, and I work in terms of delivering the drugs to or in terms of delivering anti-cancer drugs. And the other area of my research is anti-cancer drug delivery, transdermal drug delivery, and also I work a lot with ophthalmic drug delivery, that is delivering the drugs to the eye. So in the next couple of minutes, or in the next few minutes, I would like to share some of the findings we came across in the lab over the past couple of years. Before I start my presentation, I would like to start with a famous quote by Chanakya, who was a famous politician as well as a great teacher. So he quoted that Sarvendriyanam Nayanam Pradhanam. So this is a quote that is related to the eye. So I thought this quote would be a kind of perfect start to introduce my topic. So that's the reason I included this quote. So what does this mean? This means eye is the most important sensory organ. So we have 5 sensory organs, and of all the 5 sensory organs, eye is the most important one. So what is the reason behind this? because 80% of the knowledge that we acquire is through the eyes. So naturally we acquire the knowledge through touch, through smell, or through hearing. But of all these, eyes contribute the major portion. That is the reason why these are very important. And partly this is the reason why eyes are protected by several mechanisms. So I think after the brain, you see, eye is the most protected organ. And what are these protective mechanisms? First, we have the blinking of eyelids. So continuously we see the blinking of eyelids, and you see in the first picture. And next protective mechanism is the generation of tear fluids. So the reason why eyelids continuously blink is to prevent the entry of any foreign bodies into the eye. So that is the main reason. And for suppose if a foreign body enters the eye, then there is quickly generation of tear fluids. So these tear fluids try to wash away the foreign body out of the eye. And there is also a third protective mechanism, the third picture you see, which is drainage of fluids into the nasolacrimal duct. So whenever we administer eye drops to the eye, what happens is the nasolacrimal duct, which connects the eye to the systemic circulation, will automatically open, and this will lead to removal of excess fluids which are present in the precorneal area. So these are the three main protective mechanisms which always protect the eye, and these are very good for the eye. But the same protective mechanisms prevent the entry of drugs into the eye. So they pose severe challenges in terms of entry of drugs into the eye. So in the next couple of minutes, I'm going to introduce you to the structure of the eye, then what are the retinal diseases we are trying to treat, what are the risk factors, challenges associated with the retinal drug delivery, then what are the current approaches we have for treating these diseases, what are the drawbacks, and what is my approach. So coming to the structure of the eye. So most of you are already familiar with the structure of the eye. So we can categorize, or we can we can divide the structure of the eye into two segments. Mainly the anterior segment, which you see in the front part of the eye, and the posterior segment, which is the back of the eye. So the anterior segment covers approximately 1/3 portion of the eye, which is visible to the naked eye, whereas the posterior segment covers the rest 2/3 portion of the eye. And the anterior segment mainly consists of tissues such as cornea, conjunctiva, we have aqueous humor, which is behind the cornea, then you have iris as well as lens. And for my talk, I am mostly interested in the posterior segment, okay, because I am trying to treat posterior segment diseases. So we will talk more about the posterior segment, and posterior segment mainly contains sclera, choroid, and retina. So sclera is the protective coat that you see around the globe of the eye. So this is the sclera. It's mainly made up of collagen. Then beneath the sclera we have choroid. So choroid is mainly blood vasculature. We have microvasculature which nourishes the eye. So its main job is to nourish the eye. So that is the region which is next to the sclera, beneath the sclera. Then we have retina, which is beneath the choroid. So in the retina we have mainly rod cells as well as the cone cells, and also there are several neurons, and it's a very important tissue in terms of the vision process. So it is the tissue which is responsible for the vision, and how it works is, as soon as the light rays enter the eye, they are converged onto the retina with the help of cornea as well as the lens. So here you have cornea and lens. They focus these light rays onto the back of the eye, which is a retina, and these light rays are focused onto the center of the retina, which we call it as fovea, or we can also call it as macula, where we have high density of light cells as well as cone cells and rod cells. So as soon as the light rays hit the retina, a series of electrical as well as chemical signals get generated, and these signals are transferred to the brain, via the optic nerve. So here we have the optic nerve, and the brain is going to process the signals, and it's going to create the image which is sent back to the retina. So this is how the whole vision process works, and this is pretty much similar to the cameras which we used to have back in 2000s. The retina, the function of retina can be correlated to the film we used to have that was used in the camera prior to 2000. So here the most important thing is any disease that affects the retina is going to directly result in the vision loss. So that is the most important thing, and now I am going to briefly tell you about what are the retinal diseases or diseases that can affect the retina. Mainly we have age-related macular degeneration. So age-related macular degeneration is mainly going to affect the choroid region. We also call it as choroidal neovascularization, wherein we see extra growth of blood vessels. So you see this picture on the left, there will be excess growth of blood vessels. We also see the formation of deposits, and approximately around 300 million people are projected to have this disease by 2040. Then the next disease is diabetic retinopathy, which causes swelling in the retina and also bleeding of retinal capillaries. So here you see the bleeding of retinal capillaries. So mainly this is a microvascular complication associated with diabetes. So people who are suffering from diabetes at some point of time tend to acquire this disease, diabetic retinopathy, and this diabetic retinopathy eventually progresses into diabetic macular edema. So again, DME and DR combinedly, if you see by 2045, approximately 233 million people will be affected by this disease. And mainly what we see, the consequences of this disease are proliferation of retinal cells as well as inflammation of the retina. Likewise, we have other diseases, mainly glaucoma, which is due to inadequate removal of the aqueous humor which is generated in the front portion of the eye. So if there is a fluid buildup in the front portion of the eye, then this fluid buildup can cause pressure onto the back of the eye. So here, this is the back of the eye, and due to this pressure, there could be loss of neurons or death of the neurons. So eventually, glaucoma is considered as an anterior segment disease, and also it's considered as a posterior segment disease, because we have to take care of the neuronal degeneration. And next we have uveitis. In uveitis, mainly we see the inflammation of the central layer of the eye. So this is the central layer of the eye. Mainly it consists of choroid, irisillary body as well as iris. So here this is the central part of the eye. So that is also an inflammation to the central part of the eye. Again, here also we have to make sure the drug gets to the back of the eye in order to show its activity. And likewise we have retinitis pigmentosa, which is an inherited degenerative disease which mainly results in dysfunctioning of rod cells as well as the cone cells. So these are some of the important diseases that can affect the retina. Now what are the risk factors? Mainly we have the risk factor is aging, which is the most common risk factor for age-related macular degeneration. Likewise, we can have smoking. These are in general risk factors. We don't have any specific risk factors. Then obesity, family history of retinal diseases, eye trauma, and also diabetes can result in diabetic macular edema or diabetic retinopathy. So these are the risk factors of retinal diseases. Now, what are the modes of administration of drugs to the eye? So this is the most important one. So we completed a part of the introduction looking at mainly the structure of the eye as well as the diseases that can affect the back of the eye, mainly the retina. So how the drugs are administered to the eye? So the most common way of administering the drugs is topical administration. Topical administration through the use of eye drops or eye ointments or creams. So this is the most common way of administering the drugs to the eye. and this is the popular method for treating anterior segment diseases. So what are anterior segment diseases? Mainly which affect the front portion of the eye, the cornea, or it could be conjunctiva, or it could be in the iris region. So these are the anterior segment diseases. But eye drops cannot deliver the drug to the back of the eye. Okay, they cannot, because several studies have shown that eye drops fail to deliver the drugs to the back of the eye. So for treating back of the eye disorders, we have mainly systemic administration of drugs, or we can have intravitreal injections or periocular injections. So I'm going to tell you why eye drops fail to deliver the drugs to the back of the eye. Then I'm also going to explain the other routes of drug administration. So why do conventional eye drops fail to deliver the drugs to the retina? So what is the reason? So conventional eye drops means the eye drops which we find on the market, we can consider them as conventional eye drops. So when the drug is administered in the form of conventional eye drops, mainly we have the protective mechanisms which I mentioned in the first slide. So the tear turnover as well as the nasolacrimal drainage. So these two mechanisms result in loss of at least 90% of the dose that is administered. So more than 90% of the drug that is administered to the front portion of the eye is drained out of the eye because of these protective mechanisms. So we are only left with 5 to 10% of the drug, and this 5 to 10% of the drug can reach the retina mainly by 4 pathways. So the first pathway is lateral diffusion. Lateral diffusion means it's going to go laterally from the cornea. It has to cross the aqueous chamber, then lens and iris, vitreous humor, and retina. So it's directly going in a lateral manner. Again, in order for the drug to move laterally, it has to move at least 3 centimeters, which is the diameter of the globe of the eye, which is kind of impossible. Okay, drugs cannot move almost like 3 centimeters. Then we have the second pathway is transverse pathway, wherein the drug can move through the conjunctiva, then sclera, then choroid and RP. That means the drug is going to spread surrounding the globe of the eye, and then from there it's going to penetrate through into the deeper layers, that is till the RPE or retinal pigment epithelium. That is the second pathway. The third pathway could be a combination of these two, lateral plus transverse pathway. And then the fourth pathway is the drug can get into the systemic circulation because of this nasolacrimal drainage, and from the systemic circulation again it can come back to the eye. Okay, that is also a remote possibility. But what the studies indicate is less than 10,000th part of the administered dose in fact reaches the eye. So 10,000th part is nothing but 0.01%. Okay, 0.01% is not going to be effective for treating any of the diseases. So that's the reason we have to eliminate the possibility of administering the drug to the back of the eye from conventional eye drops. So now what are the other options we have? So first is systemic administration. Systemic administration means administering the drug in the form of either tablets or injections. So directly administering the drug to the body. So when the drug is administered to the body, it gets distributed throughout the body. Okay, and then finally it reaches the eye. So that means the drug is diluted by the body fluids as well as by the blood. And studies indicate that less than 2% of the drug that is administered systemically will reach the retina. Because the thing is, eye is protected by two major barriers, two major blood ocular barriers we have. So the blood retinal barrier, which is the barrier which prevents the entry of drugs from the systemic circulation into the retina. So because of these protective mechanisms, less than 2% of the drug that is administered systemically reaches the retina. So if you want to maintain therapeutic concentrations of the drug in the retina, obviously more doses of the drug should be administered systemically, which can lead to systemic side effects. So this is also not a good possibility or a good option. So next option we have is either administering the drug as periocular injections or intravitreal injections. So this is a local administration, which is kind of more effective when compared to topical or the systemic administration. So in Periocular or intravitreal injections, we place the drug either in the vitreal cavity or we place the drug close to the bulb of the eye. So in intravitreal injection, we see the drug is administered directly into the vitreal cavity. So we use a 30 gauge needle to make the injection, and so this is one of the popular methods for treating the back of the eye disorders. And as it is kind of very painful, periocular injections are also adopted. Periocular injections mean they are not injected directly into the vitreal cavity, but instead they are placed surrounding the globe of the eye here in this region. So we can have peribulbar route, or we can have subtenon route, subconjunctival route, or we have retrobulbar route, depending on where the drug is placed exactly behind the eye. So based on that, you can again further name these modes of administration. And majority of the drugs like antibodies, bevacizumab or ranibizumab, or we have corticosteroids like triamcinolone, dexamethasone. Then we have antibiotics like amikacin, clindamycin. So majority of the drugs, they are administered currently either by intravitreal injections or by periocular injections. And what are the disadvantages of these injections? First is they are non-patient compliant. That means majority of the patients do not prefer to have these injections in the eye because they are quite painful. And also it can lead to other side effects such as endophthalmitis, retinal detachment, increase in intraocular pressure, etc. So these are all some of the disadvantages of intravitreal or periocular injections. And also majority of the patients should take these injections at least once every 2 months in order to maintain the therapeutic concentrations of the drug, because the drug is not going to last in the vitreal cavity for a long time. So once every 2 months, patients, they have to go to the clinic and they have to get these injections in order to maintain the therapeutic concentrations of the drug. And patients who do not prefer to have these injections, instead they can go for intravitreal implants. So this is another technology which is preferred especially for patients who do not want to have intravitreal injections. So in intravitreal implants, they provide a long-term delivery, okay, and they are also providing local delivery because the implants are placed in the eye, so they have to be surgically placed. So we have a couple of products on the market. We have Retisert, which contains fluocinolone acetonide. It's a corticosteroid. Mainly it reduces the inflammation which is associated with AMD or diabetic macular edema. So here you see like a small tablet. So small tablet is attached to a strut, and this strut is stitched onto this scleral tissue, and this insert can release the drug for up to 2.5 years. Okay, so one insert can last for about 2.5 years. And the next generation of implants is injectable implant. Okay, so one thing I have to mention here, the Retisert is made up of non-biodegradable polymers. So that's the reason they are able to deliver the drug for 2.5 years. Likewise, Iluvien is also containing this fluocinolone acetonide, and it can deliver the drug for up to 3 years. But the advantage of this insert is it can be injected into the eye. Okay, it can, because it's a very small insert, so it can be easily injected into the eye. But once the drug is released after 3 years, again it has to be surgically removed, because you cannot leave the leftover polymer in the vitreal cavity. And then the third generation of implants is mainly using biodegradable polymers. Okay, we have dexamethasone, we call it as Ozurdex, and these are again injected into the eye with the help of 22 gauge needle, and this can release the drug up to 6 months because we are using a biodegradable polymer. And the advantages are they provide local delivery of the drug, they provide sustained delivery of the drug from months to almost years. But the disadvantages are they are not non-invasive in nature, they are invasive in nature or maybe partially invasive in nature. So that's the reason again it is associated with patient compliance. So now, what is the biggest question in front of us? Can drugs applied topically reach the retina in required concentrations? Because conventional eye drops, I told you, they fail to deliver the drugs to the back of the eye. So is it really possible to make changes to the conventional eye drop formulation so that therapeutic concentrations of the drug can get to the back of the eye. So that is the biggest question, and the best bet we have is to utilize nanotechnology. So most of you are already familiar with nanotechnology, wherein we use nanocarrier systems in order to deliver the drugs, and a variety of nanocarrier systems have been used for delivering the medications to the eye. We have nanospheres, nanocapsules, liposomes, hydrogels, dendrimers, then nanoparticles which are surface modified, and also lenses can be loaded with nanoparticles. So we have a lot of technologies, but the technology which I am going to adopt is nanomicelles. Okay, I am going to tell you why I chose nanomicelles. So we are going to adopt micellar technology. And what are micelles? Okay, what are micelles and why did I use this micellar technology is because these are easy to manufacture. Okay, both in a small research lab as well as in a bigger setting. That is the main advantage of these micelles. And also I want the final product should be clear like an eye drop solution. Okay, I don't want a suspension product, because suspensions they fail to deliver the drugs to the back of the eye. So that's the reason I prefer micelles over other nanocarrier systems. And also they have the ability to dissolve drugs that have very poor solubility. So the drug that I am going to use, dexamethasone, has very little water solubility. So that's the reason the marketed product of dexamethasone is made in the form of a suspension. And micelles have the ability to dissolve poorly water soluble drugs, because the inner cavity of micelles is lipophilic in nature, whereas the external corona is hydrophilic in nature. So these micelles, they automatically form when the concentration of the surfactant is beyond the critical micellar concentration. And so this is the structure of a micelle. These are spherical in shape, and we are trying to adopt a mixed nanomicellar technology. Mixed nanomicellar technology means wherein we use more than one surfactant. We use two surfactants in order to make the micelle, and the reason why we are using two surfactants is because they have more stability when compared to using a single surfactant. So even upon dilution, extreme dilution, we see the structures will be intact, whereas a regular nanomicelle, they have a tendency to break apart if they are extremely diluted. And we do have one product on the market which is using this technology, which is Sequa. It contains cyclosporin drug, and it is used for treating dry eye, which is an anterior segment disease. Okay, but no product is there utilizing this technology for treating the back of the eye disorders. So what is the ultimate goal of our project? It is to design and characterize a clinically acceptable eye drop formulation for delivering of dexamethasone in order to treat retinal diseases. So dexamethasone is already there on the market in the form of a suspension and also in the form of an implant. So suspension is used for topical diseases, while the implant is used for posterior segment diseases. So we want to create a product which is kind of more like eye drops, which is clear and which can deliver the drug to the back of the eye. So for this we want to use again surfactants that are approved by the US FDA for ocular use. We don't want to use any new surfactants because it becomes challenging in terms of getting approval or in terms of the toxicity studies. So for this reason we have screened all the surfactants that are approved by the FDA to see the possibility of forming mixed micelles, stable mixed micelles. And we have finalized with P80 and P40S, polysorbate 80 and polyoxyl 40 stearate. And we have noticed that these two surfactants, when combined in a specific ratios, they can form stable micelles. And the other thing is we are able to dissolve 0.1% of dexamethasone, which is the concentration of the drug in the marketed suspension product. We are able to dissolve 0.1% of dexamethasone, and we are calling it as Dexsolve, dexamethasone in solution. So the preparation process is quite simple and straightforward. I told you earlier that nanomicellar technology can be easily scaled up. Okay, whereas nanoparticles or other nanocarrier systems, majority of the products, they fail during the scale-up process. That means they make wonders when we are working in small scale, but the products, if they have to be manufactured at a bigger scale, they tend to fail. So, but the advantage of these nanomicelles is they can be easily scaled up. So what is the procedure? So first of all, we dissolve dexamethasone and P40S using ethanol as a solvent. Then the solvent ethanol is evaporated using a rotary evaporator, and we will get a thin layer of P40S as well as dexamethasone in the RBF. And this thin layer of P40S as well as dexamethasone should be mixed with the P80 solution, that means the Queen 80 solution, under continuous sonication, and it will automatically result in the formation of mixed nanomicelles. And first thing is, we looked at the CMC, or the critical micellar concentration of the nanomicelles, mixed nanomicelles. So Queen 80 has a CMC value around 12 micromolar, and P40S has CMC around 40 micromolar, and the combination of these two, we are getting CMC around 33 micromolar, which is quite reasonable, because the mixed micelles always tend to have the CMC value in between the CMC value of the two surfactants. Then we went ahead with the HPLC method development for dexamethasone, and also we have seen to what concentration we have to add these surfactants in order to dissolve 0.1% dexamethasone. So if the overall concentration is 1%, we are able to see like 0.03% of dexamethasone is getting dissolved, and as we increase the concentration of surfactants, that means a concentration up to 6%, we are able to see the dissolution of 0.1% of dexamethasone. So the final formulation contains 0.1% dexamethasone, 4.2% of P40S, and 1.8% of P80 or polysorbate 80. And then we characterize the formulation for particle size using DLS, and we are able to see the nanomicelles, mixed nanomicelles, they have size approximately 14.5 nanometers, and also the polydispersity value is close to 0.3. And also we looked at the morphology of these nanomicelles using transmission electron microscopy, and here you see these dots. They have size around 30 nanometers and 40 nanometers. So these tiny dots represent the mixed nanomicelles. Then the zeta potential value of nanomicelles is around 0.23 millivolts, because we are using non-ionic surfactants which are least toxic to the eye. Okay, these are non-ionic in nature, so that's the reason the value of zeta potential, or the zeta potential value, will be close to 0, which is 2.3. Then we did artificial tear dilution test, because once the formulation is administered to the eye, they mix up with the tear fluids, and we want the micellar structure to remain stable even after dilution with the tear fluids. So for this reason, we diluted the mixed nanomicellar formulation with artificial tear fluids, which are used in treating dry eye. Like we have refresh tears, artificial tears, gentle tears. So these are all used by patients suffering from dry eye. So we diluted the formulation like 2x, 10x and 15x times, and we have seen whether there is any precipitation of the drug. And through UV spectrophotometer, we could not measure any or we could not see any drug precipitation even after 15x dilution. That means the nanomicelles are stable after dilution with the tear fluids. Then we looked at the filtration efficiency, because ophthalmic products, one quality is the sterility. Ophthalmic products as well as injectables should be sterile in nature. And so we tried to see whether it's possible to filter the formulation using a syringe filter. We have used 3 different types of syringe filters containing PTFE membrane, polyether sulfone membrane, nylon membrane, and we have seen like the filtrate has the required drug concentration. Okay, that means above 90%. That means we are not losing any drug during the filtration process. And also the filtered sample is tested for sterility, and what we see is the filtered formulation after exposing we have used Staph aureus bacteria for this test, and you see no growth in the final picture, the D. That means the filtered formulation is sterile. That means we are able to successfully sterilize the nanomicellar formulation using syringe filters. Then we looked at the DSC. I'm going to just skip over this slide. Then we looked at the in vitro release to see how the drug is getting released. And again, the drug is getting released over a period of 8 hours. So the drug is not instantaneously coming out of the micelle, but slowly it is getting released over a span of 8 hours, which is good for us because it's showing a sustained release. Then we looked at the stability for up to 6 months, and we did not notice any significant changes. Okay, even at 4 degrees and 25 degrees. At 4 degrees, we were able to see slight turbidity in the formulation after 4 months. But again, when the formulation was brought back to the room temperature, the turbidity disappeared. So there is no major issue in terms of the clarity or the particle size or the drug content. And finally, we tested this formulation in rabbits to see whether it's able to deliver the drug to the retina or not. And so again, we used LC-MS method, liquid chromatography, tandem mass spectrometry method for analyzing the tissue tissue concentrations of dexamethasone. So we administered the formulation in 5 rabbits, the left eye of the 5 rabbits, and then the right eye was used as a control. And after 1 hour after administration, the rabbits were euthanized. Then ocular tissues were collected. They were separated, like we separate the conjunctiva, aqueous humor, cornea, iris-ciliary body, lens, retina and sclera, and the drug is extracted from these tissues and then measured with the LC-MS method, which is a validated method. And we were able to find in the retina and choroid 43.27 nanograms per gram of dexamethasone. Okay, so which is in the therapeutic range. That means 10 to 50 nanograms is sufficient to show therapeutic activity. So we are able to see 43.27 nanogram per gram of retina and choroid. Likewise, we have seen whether the formulation is resulting in any toxicity or not, for which we used the Drace test. And for this, we administered the drug 2 times daily for 7 days, again in rabbit eyes, and we tested, or we have seen the rabbit eyes for any changes, especially in the cornea, in the iris, as well as in the conjunctiva. In the conjunctiva, mainly we measure the redness as well as chemiosis. So if you see here, in cornea, absolutely we did not find any changes for almost 7 days. So basically after, we measure the cornea, or we look at the cornea under a bright light after putting a drop of fluorescein. And then iris also, we did not see any changes. And in the conjunctiva, we were able to see a minor redness, but this redness disappeared after 1 hour after administration. And chemiosis, we did not find any chemiosis. So we can say that the formulation is not causing any significant toxicity to the rabbit eyes. Then after 7 days of administration to rabbit eyes, again we euthanized the rabbits after the 7th day, and again we collected the tissues, extracted the drug and measured the drug concentration. And here also we are able to see like 67.3 nanogram per gram of drug in the retina and choroid. So even after single administration and multiple administrations, we are able to see the therapeutic concentrations of the drug in the retina. So whereas the mixed nanomicellar formulation can be self-administered, these are non-invasive and they have more patient compliance. And finally, acknowledgements. Ms. Suhi Patel is the student who worked on this project, and I would like to thank Ajman University, who is funding me for continuing the work in animal model, and also the organizers of SKICON2023, especially Prof. Trivedi, then Prof. Rizwan, as well as Dr. Sham, who were kind of did a lot of hard work, put in a lot of hard work into organizing this meeting. And the hospitality is extremely awesome, and we had a wonderful time here, and thank you all.
Very nice presentation. Very difficult to treat diseases can be addressed with such a simple formulation is a great idea. using a micellar approach. The stability study was done with at 25 degrees instead of ocular temperature like 32 or 37.
So the stability study is, we want to see whether the product is stable at room temperature or not, because the product has to sit on the shelf for at least 1 year or so, right? So we are not looking at the stability of the product at 37 degrees, because at 37 degrees means it's the temperature of the eye, 34 degrees. Okay. So because inside the eye, the product will remain only for few hours.
How long stability study was done at real time?
Real time, I told you, like we have done up to 6 months so far.
Okay, so
this is the stability, stability of the product at room temperature or at 4 degrees Celsius.
okay, pretty good. So product is stable at room temperature.
Yes.
Okay, so no need of doing the accelerated temperature. Right?
Accelerated, the problem is we cannot take a chance with the accelerated testing here, because the surfactants, they may not be stable at higher temperatures, and the micellar structure is also very sensitive, so it's taking a chance if you are doing the study in accelerated conditions.
How do you address the issue of storage stability in the tropical countries?
Yeah, so we see, the thing is, already we have products which are protein based, which require 4 degrees Celsius or maybe freezing temperatures, so it's taken care of. Okay.
Okay.
If the product is there on the market, I think the delivery wise or transportation wise, things can be taken care of. I guess it's not a big deal, because we have the vaccines which required in COVID negative temperatures for storing.
I have another quick question. So what did you measure the viscosity of the formulation?
Yeah, the viscosity of the formulation we did not measure, because it's pretty much similar to an eye drop, like water. There is no change in the viscosity. So for this reason, we are planning to add viscosity enhancers, in fact. So we added PVP K30 here. I did not stress on this, or PVP K90, polyvinyl pyrrolidine, which are viscosity enhancers. So typically we use them in eye drop formulations, and also we want to put this mixed nanomicellar formulation in a hydrogel, okay, like a hydrogel, in order to further retain the drug in the precorneal area.
Yeah, that's what my question was. Actually, if you use some in situ forming gel,
Yes.
retention will be more and unproductive loss will be less.
Yeah, we did that, but I did not still do the animal study further. So we did it, like in vitro studies are completed, but the animal study is pending for the formulation.
Okay, thank you very much. Nice presentation.
Okay.
Nice data.
This is the nano formulation. How much dose and dosing frequency you reduce
So now,
as compared to conventional?
okay. So now the marketed formulation of eye drops, which is a suspension product, I think it's administered twice daily, depending on how the inflammation is being treated. So this is, Maxidex. So this is for any anterior segment diseases like conjunctivitis or inflammation of the cornea or conjunctiva can be treated with Maxidex. It doesn't result in back of the eye concentrations. And this polymer dexamethasone implant again is an implant which is directly injected into the eye. And studies indicate that from this implant approximately like 50 nanograms, up to 50 nanograms per drug is released on a continuous basis for over a period of 6 months. So through this eye drop formulation, when I administered the drop once in the rabbit eye, we were able to get 43 nanograms, close to 43 nanograms, which is in the therapeutic range. So once a day therapy or maybe twice a day therapy, because the eye drops will show an effect for 8 hours because the drug is getting released in a sustained manner. So it's releasing for a period of 8 hours. So I think twice a day therapy would be good enough.
Do you think it's a cost effective?
Yes, definitely. T80 is dirty cheap, like it's dead cheap. T40S is also very cheap. So
Again, the technology matters.
that's the thing. So compared to an implant product or compared to injectable products, I think the cost of this formulation would be very less, or it's going to be very inexpensive when compared to the marketed products. And one thing that I want to mention here is we are using currently 6% of the total surfactant concentration, which is slightly above the approved FDA limits. Okay, we are not seeing any irritation to the eye, but still we would like to get it lower by using other surfactant combinations. But anyways, we are not seeing any toxicity.
Thank you.
Thank you, sir. Thank you so much for your words of wisdom. It will be a great pleasure for us to listen to you again in our future events. Now, I would request Mrs. Archana Patidar to present the memento to Dr. Shikha Agrawal, the session chair, and Dr. Sai Hanuman Sagar, the keynote speaker. Please, ma'am.